Welcome students to Chapter 12. This chapter concerns sexual disorders and gender variations because sometimes we do have clients that present with problems that they're having with their spouse and they're trying to improve relationships on an intimate level. Before we get started on the content, I wanted to share with you HBU's Pillar 7, which does concern life, marriage, gender, and humanness. And it is the Christian perspective on human sexuality that we do want to consider as we are approaching issues around intimate behavior of human beings. Sexual disorders and gender variations do present in our offices, and so we will have people coming for help with their spouses that they may have two types of general categories of sexual disorders going on. The first is sexual dysfunctions, and the second is paraphilic disorders. Sexual dysfunctions involve the sexual response cycle, and paraphilic disorders involve intense urges or fantasies with objects or situations that society deems inappropriate. Sexual dysfunctions are marked by persistent inability to function normally, and as many as 30% of men and 43% of women are affected in our country. The sexual response cycle has 4 phases to it: desire, excitement, orgasm, and resolution, and disorders of sexual desires affect one or more of the first 3 of these phases. This couple of graphs represent the normal sexual response cycle on the left for men, which starts with desire and builds to an orgasm and then resolution, and then for women very similar except that a second orgasm may be present. Disorders of desire involve the desire phase of the sexual response cycle when people have an urge to have sex, sexual fantasies, and attraction to others. And there's 2 dysfunctions that affect this phase: male hypoactive sexual desire disorder and female sexual interest or arousal disorder. Sex drive is determined by a combination of biological, psychological, and sociocultural factors, any of which may reduce sexual desire. Biological causes include abnormal hormone levels, and you can see that there's differences in levels of prolactin, testosterone, and estrogen that can be implicated. Also, excessive neurotransmitters of serotonin and dopamine can cause problems, certain types of medications or drugs, and then long-term physical illness. This set of drawings talks about the normal female sexual anatomy, and this is during the excitement phase when the uterus starts to tense up, and then orgasm phase when the uterus contracts. Psychological causes of low sexual desire include a general increase in anxiety, depression, or anger. There are particular attitudes, fears, or memories sometimes that produce the problems, and there are certain psychological disorders. Sociocultural causes include situational pressures, an unhappy or problematic relationship, differences in skills or need for closeness between partners, cultural standards or a double standard between men and women, sexual molestation or assault trauma, and certain psychological disorders. Disorders of excitement involve the excitement phase, which is marked usually by changes in the pelvic region, general physical arousal, and increases in heart rate, muscle tension, blood pressure, and rate of breathing. In men, the penis gets erect. In women, there's swelling in the vaginal area and vaginal lubrication. 2 dysfunctions affect this phase: male erectile disorder, which was formerly called impotence, and female sexual arousal disorder, formerly called frigidity. Disorders of orgasm occur when that peak does not happen, when the person's sexual pleasure is released, and the pelvic region normally contracts rhythmically, but some people don't achieve that. Dysfunctions of this phase for men involve premature ejaculation or delayed ejaculation, and for women, female orgasmic disorder, where they're unable to achieve an orgasm. Normal male sexual anatomy involves excitement, where the penis becomes erect, and then orgasm, where the penis contracts. Disorders of sexual pain involve genitopelvic pain penetration disorders. These are not part of the sexual response cycle, but involve physical discomfort during intercourse. Vaginismus is one of these, where the muscles tighten up on their own. This may be due to learned fear, infection, disease, or menopause, or dyspareunia, which is pain before, during, or after intercourse. When people come for sex therapy, it's normally a short-term and instructive process that involves assessment of the problem, assignment of mutual responsibility, education, identifying emotions, attitude change, mindfulness, eliminating performance anxiety, increasing sexual and general communication skills, changing any destructive lifestyles and marital interactions, and addressing physical and medical problems. Techniques that are applied to particular dysfunctions include also the disorders of desire. Male hypoactive sexual desire disorder and female sexual interest and arousal disorder are among the most difficult to treat. Typically, we're focusing on improving emotion awareness, self-instruction training, behavioral techniques to improve desire, insight-oriented exercises, biological interventions such as hormone treatments, and sometimes pharmaceutical drugs. Techniques that are applied to particular dysfunctions include also erectile disorder, which focuses on a man's performance anxiety and increases in his stimulation. Techniques involve a range of behavioral, cognitive, and relationship interventions, such as a tease technique and sensate focus exercises, different drugs, and second-line treatments if the drugs do not work. Techniques that are applied to particular dysfunctions also include genitopelvic pain and penetration disorder, where there's specific treatment for involuntary contraction of vaginal muscles. So there's practice tightening and releasing muscles, overcoming fear of penetration through behavioral exposure, and sometimes both Botox injections. And then if there's severe pain, we have clients determine specific causes, seek pain management, get sex therapy, and maybe have surgical interventions. I'll touch briefly on paraphilic disorders, but you will see more of that information in Achieve. These disorders, again, involve fantasies and urges and behaviors that are outside what society deems appropriate. So we have things like pedophilia, where people want to have sexual fantasies or relations with children. Exhibitionistic disorder, where they want to expose their genitals to others. Voyeuristic disorder, where they want to look at other people having sex. Frauderistic disorder, where they want to rub against people with their genitals. And sexual sadism disorder, where they are interested in harming someone in the process of normal sexual relations. Sometimes there's masochism also, where they want to have harm to themselves. And the performance of these behaviors indicates a disorder, even if people don't report distress or impairment in the process. And this chapter is going to conclude with a discussion of gender variations. Most people do have an identity that's consistent with their assigned gender, birth anatomy, or cisgender. Other terms that are being used presently in the literature are non-binary, people who don't identify with a gender, gender fluidity, a person whose gender can change from day to day, and then intersex, which is a situation where a person is born with different types of reproductive or sexual anatomy that doesn't fit female or male entirely. And so again, you should take all of this information in the context of the Christian view, but we do need to be aware of these presentations because it involves psychological treatment that people seek. Transgender individuals are considered non-cisgender. They have a sense that their gender identity is different from an assigned gender. It's estimated at 25 million worldwide, or 0.6% of the adult population. And the DSM-5 does define gender dysphoria, meaning an extreme incongruence and impairment between one's assigned gender and one's experience of gender. Transgender functioning is another phenomenon that you need to be aware of. Transgender women outnumber transgender men by 2 to 1. And this is where people go and have surgical adjustments to their reproductive organs, and they do things like speech therapy to change their vocal quality so that they change from a man to a woman or a woman to a man. Feelings may emerge in childhood. The pattern may disappear later, so it's encouraged that people don't engage in this process of transitioning too early in life because some of it can't be reversed. Pharmacologic intervention is considered acceptable, such as puberty blockers. Explanations of transgender functioning from the medical and psychological theorists include that some brain studies reveal similarities in transgender individuals and non-transgender counterparts in areas that affect gender functioning and consciousness. Options involve hormone administration, such as anti-androgens, gender-affirming surgery, gender reassignment, surgery. Gender-affirming surgeries do keep rising by more than 15% each year, and there is mixed research on surgery follow-up and satisfaction and perceived life improvement, so that is something that is concerning. Gender dysphoria is a new addition to the DSM-5. It replaced gender identity disorder. There is significant levels of distress and impairment involved in this. There's feelings of severe anxiety at times, or depression, sometimes substance abuse, sometimes suicidal thoughts, because the person doesn't feel like they match with their gender of birth assignment. Prejudice may be the primary reason for intense dysphoric reactions. And then I wanted to give you some information on the APA task force on how they look at appropriate therapeutic responses to sexual orientation, because those of us who do practice need to understand what the ethical standards in the field say and how it diverges from biblical teaching that is supported by HBU. So you can just take all of this into account and make your own determinations about how you are going to practice. The APA task force espouses the following as scientific facts. Same-sex sexual attractions, behavior, and orientations per se, they deem as normal and positive variants of human sexuality. In other words, they do not indicate either mental or developmental disorders. They look at homosexuality and bisexuality as stigmatized that can produce negative consequences. They look at same-sex sexual attractions and behavior in the context of a variety of sexual orientations and identities, and for some, these identities are fluid or have indefinite outcomes. Gay men, lesbians, and bisexual individuals, they believe, form stable, committed relationships and families that are equivalent to heterosexual relationships and families in essential respects. And they note that some individuals choose to live their lives in accordance with personal or religious values. And then, last but not least, there's a checklist for gender dysphoria that you can look at your leisure. And then treatments for gender dysphoria involve psychotherapy, biological, and cognitive behavioral components. Conversion therapy to like a heterosexual orientation has not been supported in the literature and can result in ethics violations. So you should be aware of that. And that is all today for Chapter 12, and I will pick up with Chapter 13.